Hello and welcome to the lower limb osteoarthritis program delivered to you from the Joint Health Physiotherapy Department at Southport Ormskirk NHS Trust. Within session 1, what we're going to cover, outline the lower limb program as you would normally see it in our outpatient department, help our patients understand what osteoarthritis is as a condition, the diagnostic and risk factors for these conditions, how we may treat it conservatively or not, and then also what exercise we can implement to help with this condition. But we're also going to answer a few important questions that can be at the forefront of our patients' minds when they come into the department. Is this going to get any better? Will it keep getting worse? Do I need surgery? Do I need a scan? But we're here to provide you with these answers. And should you feel like you need any further information at the end of these presentations, you can always get in touch with our department through your normal avenues. But to start with a bit of good news, your diagnosis of arthritis does not have to be a sentence to life of pain and or disability, ultimately leading to replacement. There are steps we can take today to start to improve your pain and your conditioning and help you cope with your osteoarthritis in the long term. The lower limb program itself ordinarily runs for 8 weeks, 4 60-minute sessions, 30 minutes of education, followed by 30 minutes of exercise. The overall aim is to provide advice, education, and helps promote self-management of your arthritic condition, improving your daily symptoms, improving those painful symptoms, improving your engagement with physical activity, and hopefully getting you back to things that you were previously doing. These videos will purely be of the education element. The exercise element should either be in department or prescribed to you at home. So, osteoarthritis, what is it? On screen you can see a few quotations that are commonly heard or used: bone on bone, degeneration, joint degeneration, age-related changes, wear and tear around the joint, and I'm sure you can think of a few other words and phrases that have been used or that you've heard before when explaining this condition. But some of these words can be quite damaging, and we assume lots of things that occur inside the body when we talk about these words. And what we try and do is stop our patients thinking about this and rather think about the condition as a wear and repair, because the disease or the condition osteoarthritis is actually attempting to self-repair. Bony spurs grow within the joint and bone starts to remodel within the joints itself, so it shows that we're trying to create new bone for those surfaces to articulate over. And these can have certain side effects, but the important part is that there's intracapsular changes, so changes that occur inside the joint that are happening all the time to help keep you mobile and maintain movement and relative flexibility. And we'll touch on the anatomy a little bit more in a few slides' time. So the first thing to consider with osteoarthritis is, yes, it's the most common form of arthritis, away from other forms like rheumatoid, juvenile, or other inflammatory issues such as gout. And it does most commonly affect those weight-bearing joints of the body, so more commonly in the hips, knees and ankles, and we probably see it most commonly in the knee. But to give you an idea of some numbers, in the United States, as of last year, 28 million people were diagnosed with arthritis, which is 1 in 5 adults. And due to our ageing population, our ability to weight bear for longer and do more as we age, that number is projected to reach 67 million in 10 years' time by 2030. And if you're over 65, you've got a 1 in 2 chance, a 50% chance of having arthritis up on those x-rays. So it's really, really common, and it comes in many different shapes and forms, different symptoms, and everybody is affected differently by the condition. But the main 4 symptoms that we tend to see in arthritic joints is joint stiffness, more specifically in the mornings, joint pain, more specifically during weight-bearing activities or loading activities. We can see swelling, but we tend to see swelling over a longer period of time, so a chronic swelling as the joint gets slightly larger over time as your arthritis generates. And then we can also see crepitus, which is just a word to describe the grinding noise that we can commonly hear in joints, and again, more commonly or more audibly heard in the knee. But if you're thinking about that number, it's a huge number, 28 million people. Will all these people need their joints replaced? Absolutely not. millions of people have arthritis with very little pain, if any, and only about half the adults with osteoarthritis are affected in their daily lives. So we think about what makes the difference. If only half the people with arthritis are actually affected by it day to day, it's not always arthritis that's the leading cause of your pain or the leading cause of your disability, and maybe it's some other symptoms that are associated with it that can cause problems, and this can include joint pain and joint stiffness, but also decreased muscle strength, decreased conditioning, and a change in activity levels. As you can see in front of you, have an image of a knee, hip and ankle joint. This being lower limb, these are the three joints that we most commonly see arthritic change in. And as you can see in the top left there, articular cartilage is highlighted on the knee joint, and this in large is the area of the joint that breaks down over time, and there's only so long this cartilage can realistically stay at the same function for, given that we use it every day. Every time we walk downstairs, every time we walk to the shops, every time we step outside, we're loaded and using this cartilage. It's very good at taking our weight, and it is an adaptive and a dynamic tissue that can repair and that can get better if we give it the right stimulation, and that's what we're going to try and promote with you as we move through here. But in large, they're the main issues that occur in an arthritic joint. The joint line or the joint space decreases, and we start to see some of those more chronic or longer term changes. More specifically, we see cartilage thinning, extra bone growth or bony spur growth, and capsules can thicken and produce more fluid. So if you cast your eyes over to the x-ray on the right hand side of your screen, the left x-ray shows a quote unquote normal knee joint, and the x-ray on the right shows an arthritic knee joint. And very simply, you can see that on the left there is a dark grey black, which indicates the joint space where there's no bone, and then on the right we can't really see such a clear joint lining or such a clear joint space, and that is a typical arthritic looking picture. And as you can see in the image above that, a joint with mild arthritis, the processed image, you can start to see where those roughened or thinning areas of cartilage can cause us some problems. And the main cartilage that is affected here is your hyaline cartilage, and that's the firm coating that's situated right at the end of each bone, and this provides a smooth surface for our bones to move over. With OA, this cartilage becomes thin, uneven, and sometimes patchy, and it can also wear out completely. But whilst this process occurs, the joint capsule, so the capsule that surrounds the joint and keeps all our fluid in there, starts to thicken over time, and more synovial fluid or more lubricating fluid is produced and pushed into that joint, so we can start to see the joint look like it's swelling slightly and look like it's larger than normal, and that's because of that process, and that occurs over a long period of time. And the important message really here is that the x-ray on the right, although it looks a lot worse off than the one on the left, that doesn't dictate our level of pain in any way, shape or form. And I've quite commonly seen patients with x-rays like the one you see on the right with no painful symptoms, and they were previously unknown that they had any arthritic problems. So the severity of the x-ray or how the x-ray looks doesn't always relate to the symptoms that our patients are experiencing, and that's the key part to take from that particular slide. How is OA diagnosed? The first three bullet points are identificatory factors for possible osteoarthritis. Doesn't mean you have it if you have one or two of these symptoms, but if you're over the age of 45, we know that you're slightly more at risk if the pain is activity related, and if you have some element of morning stiffness in that joint for up to around 30 minutes. The clinical assessment is what's going to most accurately diagnose your arthritic change, and we do this through our subjective and our objective assessment. And the subjective is just the conversation that we have with you at the start of the assessment, trying to identify trends, asking you lots of detailed and planned questions around your painful symptoms, which lead us down certain avenues of possible diagnoses. We then look at our objective or our physical assessment, how the joint is moving. We may complete some special tests, some reflexes, etc. And all we're trying to do there is successfully and as accurately as possible diagnose the issue. And this is the main reason why we don't always need imaging, or it negates the need for radiological evidence through X-ray or MRI, because they're not required to diagnose osteoarthritis. It's a relatively simple condition to diagnose, and we know that there's not an awfully long list of things that can go wrong in the knee, and we know how those present. And interestingly, many people who actually present with hip pain and stiffness don't show any radiographic evidence of hip osteoarthritis, and similarly, many people who do show evidence of OA in the hip don't have that pain. So with that in mind, we're trying to encourage you to focus on improving mobility and improving function rather than dwelling on those imaging results. And as we previously mentioned, because those results from X-ray don't directly correlate to the level of your pain or the level of your arthritis, they're not always helpful, and it's more important to concentrate on what we can change. And we know all those tissues inside your joint are adaptable, and we know they're dynamic, so we know that we can change them at least to some extent, and that's what we try to do. So if we just touch on risk factors for a moment, you've got a list of risk factors in front of you there, and we tend to group them into two different types: internal risk factors or endogenous risk factors, which are things that we can't affect: age, sex, ethnic origin, hereditary issues, etc. And then external or exogenous factors that we know we can affect: trauma, micro or macro traumas, weight, joint surgeries, injuries, lifestyle factors like drinking and smoking, etc. So we know about age, we've touched on that. As you get older, you're more likely to get arthritic change. Your engines have been running for longer. Obesity, weight or weight management problems are also a huge factor in the risk of osteoarthritis, but also in the management of it and in improving it, and we'll touch on that in a couple more slides' time. Gender as well, unfortunately, us males are more likely to get osteoarthritic changes. Previous joint injury, previous joint disease or previous joint surgery again plays a big role in risk factors for osteoarthritic change. If you've been a high-level sportsman in your youth, for example, and you've had several injuries unilaterally, several injuries down one side in a particular joint or in a particular limb, then we know those joints are a little bit more susceptible to longer-term disease like osteoarthritis, because certain factors will have been broken down earlier or broken down in different trends to what we would consider normal for that joint. And genetic factors do play a part as well. There's some evidence to suggest that if we have immediate family with early onset of osteoarthritis, then you can be put more at risk. But bearing in mind that all these factors combined don't necessarily mean that you have arthritis. We just know what factors can influence it, and the things that we can change are the most important part to concentrate on. So that leads us really into what's the best treatment for arthritis. And we know that it can't be cured. I can't cure your arthritic changes for you. They've been happening for a long, long time. There's no immediate cure, but with good management of those symptoms, we can ease the severity of those symptoms and the severity of that pain, and hopefully in turn improve your function. And we've been studying arthritis for many, many years. There's varying amount of quality within these studies, but we know what the core elements of self-care is for arthritis. Regular and specific exercise, and that's the main reason that you've come in to see us. Maintaining a healthy weight is massively important. Using good footwear, now there is mixed evidence, but there's still some really good quality evidence out there to suggest that using good, bouncy and supportive footwear can significantly help reduce the longer term risk of arthritic change. Pacing, we'll talk about more in session 2, and that's really important when we think about the management of your condition. And then pain management, again, we'll touch on more in session 2 and session 3. And in those sessions, you'll start to see a little bit more around what we can do outside of our weight, exercise and footwear. Weight management. It's unfortunate that people with knee arthritis or lower limb arthritis generally spend less time participating in physical activity. This is largely because being on your feet and doing that activity is what causes you pain, and we want to avoid painful symptoms in the majority. But did you know that our knee absorbs 1.5 times our body weight with every step we take, and 6 times our body weight every time we move down the stairs? As you can see there, that speaks for itself really, that a small amount of weight loss, even if we're not considered as obese or particularly overweight, a small amount of weight loss can do an awful lot in reducing the load that goes through our knee joint at any one time. And if we think about, the joint has increased stress from excess weight, and taking stress off that joint by losing weight makes sense. So a recent study that looked at the effectiveness of weight loss through diet and exercise, mainly on people with hip arthritis. The participants were successful in reducing their weight by an average of 5%, which resulted in a 20% improvement in physical function and a 25% decrease in pain. That's just a small snippet of evidence, but it shows that there's a huge role that weight plays within arthritis, and reducing weight to any extent is going to be beneficial, not just for your arthritis, but for your overall health and well-being. Exercise is one of the biggest things that we promote for osteoarthritis, but this slide is not about what it does for our joints, it's about the other benefits. Regular activity should be something that you enjoy. It doesn't have to be formal exercise, it can be almost anything. It can be a social outing, which is important to maintain those relationships with friends, family, etc. And we know that exercise or activity boosts happy hormones. It releases dopamine into your bloodstream and makes us feel good, and has that feel good factor. But we hear a lot of our patients, especially with long-term pain conditions, say that exercise is the last thing on their mind. And unfortunately, not everything in life is fun, and it's fine if you don't like formal exercise, you don't like a particular form of exercise. Any activity that gets you a little bit out of breath, makes your muscles work and feel like they've worked, is a good way to start. Gardening, dancing, walking, etc. There's all kinds of things that come under that bracket of activity, and we tend to concentrate on a few different elements when we think about exercise itself. So stretching and moving for flexibility. The most common complaint we hear from patients with arthritic knees is that they feel stiff, so it's highly recommended that you perform range of motion exercises, not just for the joint and the knee mobility, but also for the muscles and tendons that attach into that joint to remind them of their capabilities of flexibility. Another good way to improve your mobility is manual mobilization with your physio in clinic. But to get the most benefit, it's to focus on strengthening your leg. And several studies have shown us that strength training not only increases your ability to move that joint and the ability of strength of that joint, but also decreases joint stiffness in people with arthritis. So strong and long is the message that we try and give when we're thinking about our muscles. But if we think about what strength really is, the important part of our muscular strength is to help absorb the load that your knees take. And the muscles in that upper portion, your quadricep, hamstring, around the back of your upper leg, are really important in weight bearing and weight loading, and they play a protective role and a shock absorbing role in taking stress away from your knee. But on a positive note, quadricep strengthening has been proven to help reduce pain and improve function, and that's why a lot of the exercises that you might see in your program are lower limb dominant and quadricep dominant, as we try and strengthen that large muscle group. But we also need to have a look at some of those smaller areas of our fitness, like balance and coordination. So it's trying to test your balance and give yourself more feedback. Test that limb like it's not been tested before, because we know now what the limb can do and what the limb can't do, and what the limitations of your pain are. But try and push it, see what you can and can't do, and then talk to your therapist about it and see how we can alter the activities or the exercises that you've been prescribed. Lastly, shoes and footwear. This is something you can discuss directly with podiatry, and they can give you direct footwear advice. But as you can see from the images on your screen, the footwear on the right hand side, the laced, more supportive footwear, is always going to give you some more relief. So similarly, when we're thinking about the strength of our quadricep or the strength of our legs, playing a shock absorbing role, the quality of your shoes to some extent will play a shock absorbing role as well. So think about that footwear, and if you have any specific questions around what footwear you should or shouldn't use, talk to your physio briefly or get in touch with your podiatrist or get a referral from your general practitioner. If you do have any questions for us, please direct them towards our department and look towards the Southport and Ormskirk YouTube channel for further videos. Thank you.